Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hello, so Tom, this is going to be your Physiology Viva. Now, naturally I have to caveat that I'm not an FRCA examiner. I'm trying to make this as realistic as possible for you, and we're going to be a bit more brutal on timings with this, and I'm going to try and move you on if you're waffling. Are you happy with that?
I'm happy with that.
Okay, so Tom, this is your Physiology Viva. Welcome. How is carbon dioxide shifted from a cell to the atmosphere?
So, carbon dioxide itself is shifted in several different ways from cellular environment to the atmosphere. It's always transported in the blood, but in several different ways. Firstly, carbon dioxide itself is soluble in plasma, and this can allow it to be dissolved and then exhaled into the atmosphere from its dissolved form. It can be moved as bicarbonate through the blood as well, and then it can be at the lungs, can be metabolized back into carbon dioxide and exhaled in that way. And it's also transported bound to hemoglobin as carboxyhemoglobin.
Okay, lovely. And could you talk me through how it is stored as bicarbonate, please?
Yeah, so carbon dioxide itself, in the presence of carbonic anhydrase, can be converted into bicarbonate ions and water in an aqueous solution. So it's an equilibrium reaction which is pushed in one direction or other by the presence of carbonic anhydrase molecules. This also acts as a buffering system within the plasma as well. Would you like more detail on that, or is that what you're after?
Yes. You might expect a hydrogen ion to be formed in this process. How is that buffered?
Carbonic acid itself is a weak acid, so when carbon dioxide is in the presence of carbonic anhydrase, it forms a H plus ion plus the conjugate base of carbonic acid. This is why the presence of carbon dioxide is acidic, actually, from this process of dissociation of hydrogen ions from water in order to form carbonic acid.
And where does this hydrogen ion go?
The hydrogen ions themselves...
Oh, sorry, let me rephrase that. You've described this enzymatic process with carbonic anhydrase and the conversion of CO2 to a hydrogen ion and its conjugate base, HCO3 minus bicarbonate. Is this hydrogen ion free, or does it bond with something?
It combined with histidine residues on hemoglobin molecules, which is an important part of the buffering system in the plasma.
Lovely. Okay, so moving on. How does carbon dioxide, from a solubility perspective, relate to the solubility of oxygen?
Yeah, carbon dioxide is much more soluble in an aqueous solution than oxygen, and is therefore transported much more readily as a dissolved substance, although the majority is carried as bicarbonate in the blood.
Lovely. Okay, so we've mentioned a couple of gases here, and we're going to move on to how they influence intracranial pressure. So you've mentioned oxygen and carbon dioxide. Could you tell me how they influence intracranial pressure and what other factors may influence intracranial pressure?
Yes, so when thinking about intracranial pressure, there's, I believe, the Kelly-Monroe doctrine states that the intracranial compartment is a non-expandable space, so pressure is directly related to increases in volume within that space. There's direct effects of dissolved oxygen and carbon dioxide on the vasculature in the skull. So carbon dioxide, presence of carbon dioxide in the plasma causes vasodilatation of the cerebral vessels, and because they're dilating within a fixed space, that leads to an increase in intracranial pressure, hence focus on normocarbia in brain injury. Oxygen tension is also important, so hypoxemia itself also causes vasodilatation and an increase in intracranial pressure. So, again, expansion of blood vessels within that fixed space. Within normal physiology, there is autoregulation of blood flow within the brain. Thus, for over a range of different blood pressures, equal flow is met and intracranial pressure is maintained within fairly tight boundaries. This process can become dysregulated in traumatic brain injury, for instance.
Yes. So, what other mechanical influences exist that influence intracranial pressure?
So, mechanical influences that don't directly affect the intracerebral space may include a restriction of blood flow out of the intracranial cavity, i.e., venous congestion. So, this can be important for us when we're using ET tube ties or placing central lines, as restricted venous outflow will result in increase in intracranial pressure. And increased inflow is what we've already talked about, really, with vasodilatation. So, it's sort of two sides of the same coin.
Any other factors, or any other drugs that may influence intracranial pressure?
Cerebral edema itself may increase intracranial pressure, so that can be in response to trauma. It can be in response to hyponatremia. They're two common ways that you can have tissue damage and edema within the intracranial cavity. In terms of agents that we use in anaesthesia commonly, they're induction agents in particular. We need to pay close attention to if we're considering intracranial pressure.
That's your 5 minutes up there. So, moving on the topic of oxygenation, what physiological changes occur in the neonate when they're exposed to the higher oxygen environment of the ex-utero world, and what occurs when you clamp their umbilical cord?
It's easy to think about this in relation to the circulation of the fetus initially, and then how that changes at the point of birth. Normally, within the fetus, we have various mechanisms that shunt the most oxygenated blood into the cerebral circulation. They do this by shunting from right side of the heart to the left without going through the lungs. Within the fetus, there is potent hypoxic vasoconstriction of the pulmonary vessels, which helps increase resistance in the pulmonary vascular bed and contribute to this right to left shunt. This occurs across the foramen ovale between the right and left atria. At birth, a few things happen at once. When baby starts to take its first breaths, that hypoxic pulmonary vasoconstriction is strongly inhibited in the presence of atmospheric oxygen, and the vascular resistance in the pulmonary bed reduces massively. This means that the pressure gradient across the right and left atria reverses. The foramen ovale, which is structurally essentially a flap valve, closes without necessarily sealing, but the pressure keeps that, like I say, a flap valve closed. Blood begins to move much higher volumes from the right ventricle into the pulmonary tree, and is oxygenated and moves into the left atrium and then into the systemic circulation in the way we're familiar with in adults. So are you able to repeat the question as well, just so I can be clear exactly what you're looking for?
Yes, that's fine. On the topic of oxygenation, what physiological changes occur when A, there's a presence of a higher oxygen environment ex utero, and B, when the umbilical cord is clamped?
And you asked about the clamping of the umbilical cord as well. So when the umbilical cord is clamped, we have immediate reduction in or cessation of placental blood flow to the fetus, and we also have reduced venous return from the fetus to placenta as well. Essentially, we have constricted the circulating volume, and as a result, we've increased the peripheral vascular resistance for the fetus. So that leads to a rise in the blood pressure of the fetus, and also that increase in pressure allows for increased oxygen delivery throughout the systemic circulation.
And how does that increase in peripheral vascular resistance relate to the pressure in the left ventricle versus the right ventricle?
So yeah, as we were talking about before, there is a reversal of the pressure gradient between the left and right ventricle, and that increase in pressure from the reduction in peripheral volume and increase in peripheral vascular resistance contributes to that reversal of right to left shunt to a normal circulation.
Okay. And where is the ductus arteriosus?
The ductus arteriosus sits itself between the pulmonary artery and the arch of the aorta, allowing for right to left shunting of blood away from the pulmonary circulation in the fetus.
Okay, lovely. What influences the closure of ductus
So,
arteriosus?
ductus arteriosus itself closes in response to endogenous prostaglandin release. This is
And we'll stop you there. So, Tom, how did you feel that went from a physiology Viva perspective?
It felt okay, but it was on this particular question, I found myself trying to simultaneously figure out what was required from the question whilst having to speak. And I tripped over myself a little bit and I think was a little bit circular in places because as soon as you come onto the fetal circulation, it feels like quite a big topic. There are quite a lot of things to say. There are quite a lot of facts that we might have picked up at various points in revision. But I was trying to stay focused on the question and not start getting into things that weren't asked for. But yeah, that caused me to hesitate a little bit and be a bit less fluid than I would have liked.
Yeah, I think you've brought up quite an important point there is that you have to answer the question that is asked of you. So when we went on to the neonatal circulation, you told me some stuff about in utero neonatal circulation, despite the fact that that's not the question I asked you. If you're trying to demonstrate that you have an idea about the neonatal circulation, do it in 10 seconds. I think you spent about a minute describing what in utero was, when really I was asking you what happens ex utero, i.e., that first breath and what changes occur. So you might have found yourself losing opportunities to get points by answering the question you thought was asked. But it's good that you then went back and actually re asked what the question was. That is absolutely fair game. And you might think it costs you time in your 5 minutes, but if you've meandered off piste, taking that opportunity to refocus might get you back into past territory.
Yeah, and just on the grapevine, you do hear that examiners are generally quite good at redirecting you if you're going down a rabbit hole, but there is some variability there. Some people don't interrupt you quite as brutally, and you can waste a bit more time. And having ways to refocus yourself, I suppose, can be helpful in some situations.
Yeah. Just in terms of key points we were hoping for across that, when we were talking about the journey carbon dioxide takes from cell to atmosphere, the key words would be it's highly soluble, so it moves across membranes very quickly with diffusion. The reaction that takes place is H2O and CO2 via carbonic anhydrase, which is a very, very active enzyme, into H2CO3, which then disassociates into a hydrogen ion and HCO3 minus bicarb, and that hydrogen ion gets neatly mopped up by hemoglobin so that it's not pottering around causing bother.
Also, it is important to consider the respective amounts of CO2 transported between these two methods, but also carbamino compounds. So about 5% of CO2 is dissolved and transported in plasma. 60 to 65% is transported in bicarbonate through that enzyme system described. And 20% or so is transported directly bound to hemoglobin as carbohemoglobin or carbamino compounds.
Yeah, and I suppose another thing to reflect on there, it's a topic that I felt that I knew, but then in the pressure of the moment, I made a conscious decision not to commit starting to describe the chemical reactions because I thought I might get it wrong and trip myself up. So I suppose you sometimes face those decision points, and in an ideal world, it's on the tip of your tongue and you know it well. But yeah, I kind of didn't want to start tripping myself up by saying the wrong things.
Yeah, and that's definitely a balancing act because it could have been that actually that was the key element that they want out of you. And I imagine if that is the case, they might start pushing back and trying to get you to commit, as opposed to letting you dance around the edges. I think that's examiner dependent. And then the last point, we were looking at cerebral perfusion pressure, and it might have been my wording of the question that made it a bit awkward.
So, just to comment here, I've had this exact question practice with a consultant at work, actually, and I think they used very similar wording to you, and I think I tripped myself up in the same way because cerebral perfusion pressure itself doesn't affect intracranial pressure, at least not in the way I think about it. So I was trying to answer the question and not start saying things that you didn't want to know about. I thought they're not asking about cerebral perfusion pressure because I would naturally wait for a more clinical dint of line of questioning to say, and what things can we use to control cerebral blood flow or something along those lines, because it was while we were vivaing, I was thinking about cerebral perfusion pressure, but I made perhaps the wrong conscious decision not to go down that route because I didn't think that's what was being asked.
In my head, I think it was intracranial pressure I was going for, but the crux would be if we were going down the intracranial pressure route, you could say very quickly, carbon dioxide tension causes proportional vasodilation. Low oxygen tension leads to vasoconstriction. There are ways that we clinically alter this with drugs and positioning, and this is all derived from Monroe-Keller doctrine.
I think it's, like I say, I've kind of fallen into the same trap before, so I don't think it's the way you were wording it, but I guess it's just a lesson in not tripping yourself up a little bit as well. And if there's a core topic that seems relevant, so long as you don't spend too much time, if you can within 5 seconds state, and cerebral perfusion pressure, which is the difference between the mean arterial pressure and the intracranial pressure, dictates blood flow and oxygen supply within the brain. That took no time at all. If they're not after it, they can move you on.
Exactly.
If you spend a minute and a half doing that, then you've not really hedged your bets if you're not sure what they're after. So yeah, the technique point again, I guess.
And we'll stop it there, Tom. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest alive for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.